All right, let's jump straight into a topic that is just foundational to reconstructive surgery: tissue expansion. This is a really high-yield area for residents preparing for board exams, and we really need to get past the simple definitions and into the physics, the biology, the things that truly define a successful expansion.
Exactly. It's such an elegant tool, and, understanding its history gives some useful context.
Hmm.
While just mobilizing tissue is ancient, the therapeutic use with the device was first described by Newman back in 1957. It was really popularized later by people like Radovan and Ostad.
Right.
And the reason it's still a cornerstone for us is because it lets us reconstruct using sensate skin with an almost perfect match in color and texture. And you do all of that while leaving the donor site with, minimal deformity.
That's the core promise, isn't it? The perfect tissue match. So our mission today is to really break down the mechanics. How do we actually manipulate that skin envelope to get the gain we need, and also distill the critical clinical rules for using it safely? So let's start with the fundamental science. If you had to identify the two main mechanisms driving tissue gain and, say, approximate their proportions, what are we looking at?
This is the first thing you have to memorize. It's a combination of two forces. You have mechanical stretch and you have biological growth. And the split is roughly 70-30. So about 70% is from the stretch, what we call mechanical creep, and the other 30% is from genuine tissue growth or biological creep.
70% mechanical. That's a huge proportion. It really implies that a lot of what we're achieving is just pure physics and tension.
It is.
And when we discuss this physics, two terms always come up: stress relaxation and creep. In the context of skin's viscoelastic properties, how are those two different? And why is it so important for a surgeon to understand both?
It's crucial not to mix them up. So, stress relaxation. That happens when we subject the tissue to a constant strain. Think about a fixed volume of saline in the expander. Over time, the internal tension in that tissue actually decreases.
Okay, so that's why the expander doesn't feel as rock hard 24 hours later as it did right after you filled it.
Exactly. Less force is required to keep that skin at that new volume. The tissue is just accommodating the immediate stretch.
And what about creep?
Creep, on the other hand, well, that describes the time-dependent, permanent deformation that happens in response to constant stress. This is the plastic, the lasting change. So stress relaxation explains the immediate accommodation, but creep is what explains the lasting tissue gain.
So stress relaxation gets us ready for the next inflation, but creep is what actually gives us the new tissue we can use for the reconstruction. And you mentioned tissue creep relies on 4 specific mechanisms. Can you detail those for us?
Absolutely. That 70% mechanical component is driven by these 4 structural changes. First, you have the disruption of elastin fibers. These are the elastic structures, and they get disrupted, which reduces the tissue's tendency to just snap back.
Okay.
Second, and this is probably the most important one, is the realignment of collagen. The collagen fibers don't go away. They reorganize themselves along the new lines of tension from the expander. This creates a wider, thinner, but still strong scaffold.
And the other two?
The other two are more immediate effects. You have fluid displacement, where interstitial fluid is basically squeezed out from under the pressure. And fourth, you get migration of local tissue, where adjacent mobile tissue is pulled into the expanded area.
That realignment of collagen is fascinating. So you're not just stretching a weak structure, you're re-engineering a strong one. That brings us perfectly to the histology. When you put this tissue under a microscope, what are the classic changes you see in the epidermis versus the dermis?
The changes are predictable, and they're often tested. In the epidermis, its thickness usually increases or can stay the same as unexpanded skin. But the vital finding here is that the mitotic rate of the basal layer is significantly increased.
Right, that's the 30% biological creep in action.
Exactly. It's direct evidence we're genuinely generating new epithelial tissue. But then you look just beneath that at the dermis and you see the opposite. The dermal layer actually decreases in thickness.
Because the collagen is spreading out.
Right. It's the consequence of that realignment. And as the skin gets pulled tight, the skin appendages, hair follicles, glands, they get physically separated. That's why when you expand a scalp, you see a noticeable drop in hair density.
So new cells on top, but the underlying scaffold thins out. What about the deeper structures? Subcutaneous tissue, muscle, even bone. What's happening to them?
Well, those tissues are all about pressure. The direct, unrelenting pressure from the expander can cause localized atrophy, specifically of the subcus, the muscle underneath, and in some cases, you can even get pressure resorption of the underlying bone. It's a critical thing to consider during placement.
Let's shift to vascularity, because the reliability of that expanded flap is everything. It's often taught that expanded flaps are superior. How does that mechanical force we apply actually improve the blood supply?
The vascular benefit is one of the most powerful arguments for this technique. The mechanical force actually preconditions the tissue. It improves the vascularity of both the overlying dermis and the expander capsule that forms right under the device. Perfusion studies show total capillary blood flow and the axiality of the flow are both significantly increased.
So the expansion itself is acting like a flap delay.
A superior method of flap delay, in fact. The resulting flap is already robustly conditioned. It offers improved flap length survival that's equivalent to, or often even better than, what you'd get from a conventional delay technique. You're creating a much safer flap.
And since that capsule is now part of our reconstruction, let's get into the high-yield specifics. Posick described 4 distinct zones. What are those 4 layers, starting from the silicone surface and moving outwards?
Yes, this is a classic. So, number 1, the inner zone. Right next to the expander, it's a thin fibrin layer with macrophages. It's your basic foreign body reaction.
Okay.
Second, the central zone. This is the thickest, most organized layer. It's full of elongated fibroblasts and, crucially, myofibroblasts. And they're all pressed between these thick bundles of collagen that are oriented parallel to the expander's surface. That parallel alignment is what gives the capsule its strength.
And the outer layers.
The third is the transitional zone. It's kind of moving back toward normal tissue with looser collagen fibers and a few blood vessels. And finally, the outer zone. This is where you have an established, well-developed vascular network and loose collagen, and it interfaces directly with the normal surrounding tissue.
That central zone really is the key, acting like a preconditioned scaffold.
Okay, let's move from the microscopic to the macroscopic surgical planning. When you're putting the expander in, where do you make the incision? And how do you decide on the depth of the pocket?
Incision placement is absolutely key to avoiding complications. A remote, radially orientated incision has the lowest complication rate.
Why is that?
It just maximizes blood flow to the incision margins, and it keeps the wound away from the point of maximal tension. As for depth, it's very site-specific. Subcutaneous placement is what you'd prefer in the face and trunk, where you need the skin to stay mobile. But in the forehead or the scalp, where the skin is tighter, you'd prefer subfacial placement. It gives you a much firmer, more stable base and minimizes movement.
And a really practical point. The filling port, you want it over firm tissue like a rib or the iliac crest. What's the risk if you don't do that? Well, if you put the port in soft, mobile tissue, every time you try to inflate it, the port itself just moves or slides around. It makes a safe needle insertion extremely difficult. And it's worth noting here, complication rates in the limbs are consistently reported to be higher than in other sites, mainly because of the lack of stable deep tissue and all the mechanical stress from movement.
Right, safety first. So before you even make that incision, what are the absolute non-negotiable contraindications for placing a tissue expander?
There are 4 critical ones where the risk of failure is just too high. First, in the vicinity of an immature scar. That scar tissue just can't handle the tension. Second, in the presence of an active infection. That's just asking for an infected implant. Third is in irradiated tissue where the vascularity is severely compromised. And fourth, under skin grafts. Grafts just have an unreliable blood supply and they're prone to breaking down under tension.
Let's talk about the hardware itself. Expanders aren't all the same. Beyond just size and shape, the envelope composition is critical. Can you define the difference between isotropic and anisotropic expanders?
Certainly. This is all about controlling the direction of expansion. An isotropic expander is what most people picture, a uniform balloon. It expands equally in all directions because the shell is uniform. It gives you a sphere or a uniform oval.
And anisotropic.
Anisotropic expanders are designed differently. They use variations in shell thickness, maybe a stiff backing, to control and direct the expansion. So an anisotropic expander, because of that backing, is more like inflating a football. It only bulges out where the shell is pliable, so you can focus the tissue gain exactly where you want it.
And we also see special shapes, like the crescentic or croissant-shaped expander. What's the benefit there?
They're really designed to result in shorter donor defects and minimize those dog ears at the ends of the flap. By concentrating the expansion force over the central part, you get less tension and redundancy at the tips.
And just quickly, on ports, the main risk with a remote one is flipping.
Correct. Remote ports give you placement flexibility, but the big mechanical risk is that the port can rotate or flip once it's in, and then it's impossible to cannulate safely until you surgically reposition it.
Let's touch on an interesting alternative, especially for pediatric cases. Self-inflating expanders. How do they work, And why have they historically been so risky?
The appeal is obvious. You avoid repeated office visits, repeated needling. These devices have a hypertonic compound, and they fill gradually through osmosis. They just draw fluid from the surrounding tissue across a semi-permeable membrane.
But the historical problem was control.
A huge problem. The early ones used hypertonic saline, which led to uncontrolled expansion and, well, widespread tissue necrosis, a major failure. Newer ones, like the Osmond system, use a hydrogel, and the expansion rate is theoretically controlled by hole in the shell. But even with these advances, high complication rates are still reported, so their use is still highly debated.
Okay, that brings us to the final variable, timing. There are three very different ways to approach the inflation schedule. What are the main protocols?
The timing really dictates how much you're leveraging mechanical versus biological creep. First, there's intraoperative expansion. This is immediate, sustained traction applied right there in the procedure. You might use hooks or devices like a Foley catheter to just maximize that initial mechanical creep and help with primary closure.
And the faster post-op option?
That would be rapid expansion. Here, you inflate the expander every 2 to 3 days. The rationale is that most of the tissue creep and the initial growth happens in the first 48 hours, so you're trying to speed up the whole process.
But the most common is still conventional.
Yes, conventional expansion is still the standard and, frankly, the safest approach. You inflate the expanders weekly. This gives the tissues enough time to stabilize, for that stress relaxation to happen, and for the new vascular network in the capsule to mature. It's a balance of gain, safety, and comfort.
Finally, we have to talk about complications. They do happen, and residents need to classify them correctly. How do you distinguish between a minor and a major complication in this context?
It all comes down to their impact on the procedure. A minor complication is one you can manage without stopping the expansion. Maybe some temporary pain or a small hematoma that resolves. A major complication is one that forces you to terminate the expansion and remove the expander.
And what are the most common critical examples of those?
The big ones often relate to device failure or tissue breakdown, so exposure or extrusion of the expander, which is usually from marginal skin necrosis. Severe infection that requires removal is a big one. Then you have complications from pressure, like neuropraxia from compressing a nerve, and don't forget the technical issues, accidental perforation of the shell, or, as we just mentioned, the flipping of a remote filling port.
That's a really comprehensive review. It ties together the physics, the biology, with that key detail of decreased dermal thickness and increased basal layer mitotic rate and all the clinical decision-making.
And you just have to remember that foundational principle. The mechanical force of expansion preconditions the tissue. It creates a superiorly vascularized flap that performs as well as, or even better than, a traditional flap delay. It's tissue engineering by physical tension.
As we wrap up this deep dive, here's a final provocative thought for you. The clinician getting ready for practice. Given the high complication rate we know is associated with self-inflating expanders, how do you balance the clear long-term psychosocial benefits, specifically avoiding repeated needling and trauma in kids, against the known surgical risks and the potential for expansion failure? It's a real clinical calculus of benefit versus harm in our most vulnerable populations. This has been a focused breakdown of tissue expansion principles.